My name is Kausik K. I'm Professor of Public Health at Imperial College London. I'm Director of the Imperial Centre for Cardiovascular Disease Prevention, and I'm talking today about our late-breaking abstract at the EAS Congress 2019. So the topic in question is one about familial hypercholesterolemia. Now, we know that familial hypercholesterolemia affects around about 1 in 200 to 1 in 300 individuals globally, and we know that there is underdetection and undertreatment. Now, the case for detection of FH might be helped if we had data, for example, on the absence of making a diagnosis in individuals at high likelihood of having FH and consequently adverse outcomes. Now, this sounds intuitive, but you have to try and show this with an experimental design. So how does one do that? It's very difficult to do that as a randomized trial. So our approach here was to use big data and routine electronic health records. So in the UK, we have data from GP systems that cover about 15 million people. And as any of you who've worked with this type of data will know, there are some missing variables and various things that we have to take into account. But at the end of the day, we were able to get a cohort of about 1.7 million individuals. And we looked at data between 2008 and 2013. So the first thing is we looked at the proportion of people who had a coded diagnosis in the GP records compatible with FH. And what we did was then we compared that with individuals who didn't have a coded diagnosis of FH, but who, on the basis of Dutch Lipid Network criteria, could either be considered as having probable or definite FH, and we call those two potential FH. And if you didn't fall into either of those two categories, then you would be considered FH unlikely. So in the analyses that we conducted, we found that the LDL levels between the FH potential and the FH coded group were very similar. When you compare that to the people who were considered FH unlikely, it was much higher. And if you look at age-specific event rates, the highest event rate for fatal and non-fatal cardiovascular events was in the FH coded group compared to FH unlikely, and the FH potential group were similar, but a little bit less at every specific age. So one of the key questions is that these people who essentially had LDL cholesterols high enough to be considered at possibly FH or potentially FH, but who didn't have that diagnosis, were their outcomes worse compared to people with a diagnosis? Because we know that making a diagnosis might change behavior, lifestyle, adherence to medications. And what we found is that even when you account for other factors, compared to people with an established diagnosis of FH, premature mortality, that's dying from any cause before the age of 60, was higher in the FH potential group. It was 88% higher. In comparison, if you look at survival, even though FH-coded individuals might develop cardiovascular events, their survival was actually fairly similar to those people considered FH unlikely. And an important key message is at the age of 18, if your LDL cholesterol levels are high enough for you to be considered as potentially having FH, but you do not have a diagnosis, you lose 16 years of life. So what we think this does is it really does, again, support what many of us believe, that we should be looking to screen and identify people early, perhaps by universal screening for cholesterol, to then identify people with FH earlier and institute treatment earlier, because that might then impact cardiovascular outcomes.